one of my questions to the developers are the language. I've checked a couple of the apps, and it seems to me that they are in English right now. And of course, it's a minor thing, but I think in order to be attractive to all kinds of patients, I think it's worthwhile, or my recommendation would be that you need to think about the language issue. So that's at least one question I could have to you. Is that in your timeline to also translate into a national language?
Yeah, I might take that first, and of course I fully agree that once you have an app that delivers a value that you're certain of, and then it's about how do you make it accessible to most people, so they can really fully take advantage of it. You need to go localized. That means both the language aspect, but there might also be other aspects in terms of that the information may be provided, linking into the specific healthcare system. The balance, the tricky one, is that in order to do that, it takes quite a lot of effort, which slows you unfortunately down in iterating on the technology, on the app, and we see ourselves still in a phase where there's a lot of ideas and feedback that we've gotten from people using the app, people living with psoriasis, but also other skin conditions, on how to improve the app. So we would like to still make the app first a lot better, and then slowly looking at localizing and translating.
We were just discussing this even before we got in, because we were saying what are the major challenges that you're facing, and this is one of the challenges. We know that because the everything needs to be clear, and with SkinVision we're available in English, in German, and in Dutch. But we also notice the moment that we add a language, we become a lot slower in processing, in progressing, and bringing new versions of the service to the application out to the public. But we do see that with German, which we now started in February, that the adherence as well to the program is like tripling, because people are understanding what's happening. So for us, this is we are planning on, at least in the upcoming year, to add 5 new languages because of this. But it also means that we need to scale as a company, because it's unfortunately a lot more difficult than just adding a language. It's also the maintaining, providing the customer support that goes with it. But if we want to reach our goals, we will have to, because otherwise we see what the effects are.
And then specifically to SkinVision, I don't know if you're aware, I'm sure you are, but the Danish Dermatological Society actually had a look at SkinVision and other apps, trying to not diagnose, but trying to estimate if the mole you have is actually a malignant or not. So I don't know if you are aware that the Danish Dermatological Society was kind of critical in that sense, that there might be some false security, and the accuracy of SkinVision was questionable. This was a survey that was done 1.5 years ago, and I'm sure and I'm confident that the technology and the IE and the machine learning that you were also introducing will help in being more precise in the diagnosing. But there are still some issues in do you really obtain a security, false security? And again, the disclaimer from your app, now I have that hat on, but the disclaimer is very large. So what in the case if there is a misinterpretation?
Yeah, no, this is definitely something that, so yeah, of course a lot has happened over the last 1.5 years, and we become better, but as I'm saying, like, we are not at 100% accuracy, and we will never get there. And with the number of photos that we're doing, there will of course always be, there will be false negatives. But on the other hand, that's also the case with GPs and dermatologists, but it's, okay, but even then, the biggest disclaimer that we have, and even though I would like to give a diagnosis with the application, because in many cases we can, is that we don't give a diagnosis, because we don't want to get into this field, because we know that there will be cases where we're missing this. The most important thing is, so we can give if you give off a high risk where it's low risk. In fact, those are not the cases that worry us too much. We rather give a bit much too high and not miss anything. It are the cases where it's low and we might be missing something. But that's what we're doing with all. But that's why every photo is checked by one, and most of the times even two dermatologists. So that we're not just relying on the algorithm, we're also relying on the human dermatologist afterwards. So the false security, I don't think that there's false security in this because of the fact that we do the entire follow-up. It's not just you get the low, medium, and high risk, but we make sure that we check up with you and we check the photos and we will come back to you in the end. So it's not just, if it were just the algorithm, then yeah, but it's not just the algorithm, it's the entire team of dermatologists afterwards doing also the quality check.
I think maybe we should ask Stine and Alex. I mean, sun is something that is beneficial for the skin of psoriasis people. The question is, would you use an app for that if you suddenly discovered that because you have had a lot of UV exposure and actually use that app, or how would you, what's your feeling?
I actually do it like maybe once a year. I go to an old dermatologist, so I expect he's quite experienced, and just to get checked over, because I do tend to like to be in the sun because it helps my skin so much, but I also want to keep track on it. What I feel in order for skin vision is that it's easier for me to use a phone and just check it fast than necessarily have to make an appointment for a dermatologist, and it takes a while before you get the time and everything like that. So I think it's a really helpful tool, and then maybe it's just important to be sure that you can not only rely on a photo that you take yourself, you have to go see a dermatologist as well if you're really in doubt. But for instance, it's a really good idea if you can just walk into some machine who can take a total photo of you, and then you can detect that there, and there. Maybe you should have looked at these 3 spots, but I think it's important to do, yeah.
I largely agree with what Stine is saying. I mean, I've got birthmarks all over my body, so if I had to document them, each one individually, I could do nothing but that. So I probably wouldn't do that. But the full body scanning, that sounds very interesting because, I mean, that would be like a one-off thing, and then someone would let me know if there's something I need to check up on.
Thank you. Well, I'm Camilla. I'm president of we call it Junior Doctors Association. It's half part, you could say, of the Danish Medical Association. A junior doctor is from the newly educated to the specialist, and it's not the consultants, and it's not the one who owns clinics, but the rest is junior doctors. And I have a lot of things today. I would like to comment on everything, but we actually in the Danish Medical Association and also junior doctors, we greet the new technology. We see it coming and we think it's exciting, but we also have some focuses on that technology, AI, digital solutions in every way, wearables and sitables, should add quality. And it should add quality to the patient experience, and I hear that for you, certainly Alex. I also hear that from you, Stine, in getting a lot more knowledge to your own condition. But it should also add quality to, for example, the work we do, doctors do, nurses do. And it should also have some kind of, what we call it, economic aspect. It should be beneficial also in the larger, broader perspective if we embrace technology in a society. And if I should start at the end of what you just said about the full body scan. The full body scan has been dealt with at several points. A lot of firms, companies have talked about doing this full body scan. Now it's the skin, but some have also, someone selling machines doing full body scans have talked about why shouldn't we just, when people come to the emergency room, just run people through a scanner and then we just know everything, and then we could just right away address everything. And there you should know that a lot of things goes on in our bodies that are not actually diseases. And we have a lot of weird things in our bodies that actually doesn't do anything. They are just there. But if we diagnose them by coincidence, we tend to actually give the patients a lot of examinations, a lot of unnecessary things, just because we saw it. And we do that today. We do it in several areas where we see some symptoms in a patient that actually leads to a CT of the abdomen, and sometimes we see something else we also need to take care of. And that's of course good because it starts with a symptom, but we find something else. If we just scan everyone without symptoms, without any suspicion of disease, we tend to overdiagnose, and we tend to overtreat, and we tend to over-examine. And that's not for the patient very good, and it's not in economical way very good. So that's the stuff for me in just doing everything because we can. So we need to be very critical about what we do, and we need to embrace technology by testing out what can we use and what can we not use. I would like to hear you, Stine and Alex. Have you thought about the data you could deliver? You have tried it. You deliver a lot of data
Sure I do.
to a company. Do you know what they use? What do they do with the data?
No, I don't really. But also, I don't feel like, I mean, in terms of privacy and stuff like that, I don't feel like I've got anything to hide there. I'm very open and frank about the fact that I've got psoriasis, and whatever I'm saying here or in any interview, I would say anywhere else. I mean, I don't feel like I'm putting myself out there or making myself vulnerable in that sense. I mean, I'm sure I am. I mean, I'm sure someone can use it to some malintent, but I don't really have much to fear there at all. I don't think that.
I also, the same way, no, I feel just that you have to have a bit of openness in order to move forward. And for me, it's just been really interesting to get answers on some of all the questions I had, but I didn't have the knowledge. Like, if I look back, I should probably have become a dermatologist, because, it's just, you need these answers, and I have definitely not gotten them from the doctors.
No.
And I feel the lack of combining different areas of knowledge together in a place. For instance, it's a great venue for it, Bispebjerg. Mm-hmm. It's a huge place, the whole building. It would be great if you can put more kind of like different kind of people in there, get a better view of how to deal with this. Yeah.
I also had the pleasure of sitting
if
at...
I could just,
I'm sorry.
because
yes.
I would actually like to hear the companies. Do you have any ethical considerations? Do you have any transparency about what the patients bring on with the data?
Yes, so when both in the description of the app, when people start to use the app, we're very explicit about that. We're using the data to train kind of machines, algorithms with it, and that's also what I presented today, and that is what we are using the data for. Of course, strictly complying with the latest GDPR regulations, HIPAA in the US. We take very big efforts to make sure that the data is de-identified. Means, of course, there could be pictures of faces, etc. But even there, we have all the mechanisms in place to make sure that we deal with them in the right way. Here we are, of course, also maybe in the lucky position that the Leo Innovation Lab is part of the Leo Foundation, so there is a higher mission to it, and it's not a publicly listed company that is pressured by external market forces as such. So I think the question is always relevant, but it shouldn't be the first roadblock. I think there are more important aspects to often discuss, how we can really bring together the different stakeholders to bring the technologies faster to market. That could also be an ethical consideration.
Yeah, no, this is definitely something that we discuss a lot. Just the GDPR, which everybody keeps talking about, which is, of course, a big driver of this discussion. What we do have is that everybody has to agree with their photos being looked at by a dermatologist and the machine learning algorithm. Without, we simply cannot allow you to make a photo, because that's how the entire system works. And I think one of the things that we as a company try to do as well is, like, the difficulty most of the time is that you don't even know how an algorithm works or what they look at. It's a black box, it's a neural network, it trains itself, so most of the times we don't even know exactly what they're looking at. So what we try to do within Skin Vision at least is explain how it works and what we look at and what the kenmerken, the properties are that we train on. And what we also do is that but it's also GDPR. If you say you can't use my data anymore, then you have the right to be forgotten.
I think just to add to that from the DNA perspective, so obviously it's very, very sensitive information, and we have to, of course, be completely compliant on how we're storing it, so we're very careful with this. It's also de-identified, so of course it's matched to the disease and maybe it's matched to photos, but it's this code. So if you were to, I don't know, hack in somehow and get hold of this data, it would be completely useless and you couldn't identify the person from it. And also that at some point, if someone wants to withdraw this and say, okay, I don't want to be part of this, I don't give my consent anymore for you to use my DNA data, they always have this option.
And on that note, I was going to say also, thank you, that I also had the pleasure of being the Danish patient, the umbrella organization's representative in the board for implementing precision medicine in Denmark. And one of the issues that had been discussed there amongst patients and citizens is the use and the storage of DNA data. And you were very open and frank in your presentation, saying that you want everybody to take a DNA test. That is not the meaning of the implementation of precision medicine in Denmark. You know all of that. And I think it would be to go too far. On the question of data security, my question would be, being a commercial company, again going back to the ethics, what considerations do you have and what have you met from patient sides on sharing their data? Now we hear that Alex is willing to share all his data, and that's fine. To some of the research that has been done prior to implementing precision medicine in Denmark and the process we're in there right now is the insecurity where those data end up. And the insecurity of the data ending up to commercial companies, to insurance companies, that is dealt with in the insurance law, so that is not really an issue in Denmark. It might be in other countries. But what considerations have you done being a commercial company on something so critical and extempore as DNA data?
I mean, I think it's hugely important also. Also because I think getting a DNA test is really cool and really important doesn't mean that everybody thinks that, and a lot of people rightfully are skeptical or worried, or they just don't want to do that. And yeah, a big part of taking DNA samples and having this in the database is giving the person autonomy and giving them some choice and some options about what happens with their data and what it's used for and where it's stored and when it can be withdrawn if they want to withdraw it. In terms of, obviously another big concern is, will my DNA data be used by the police? Will you give it to to insurance companies, and will it affect my future in some negative way that I haven't thought of yet? And at least for my project and from our perspective, the data will only ever be used for research, and that's it.
But that's your perspective.
Yeah.
Maybe I can zoom out a little bit and say, I mean, just to challenge all of you, right? Yeah. So, how much information about people with a disease is actually reflecting the DNA, right? Human genome was sequenced, you know, a long time ago. We thought that was the key to the knowledge about diseases. Where are we today? 5% of a disease phenotype is based on DNA. 5%.
Yeah, and that's
40% is based on the environment.
Yeah.
And in the environment, you can add on at least 40% that is based on your behavior as a person, your data on social media. So what I'm saying here is that we can learn much more from maybe social media than the DNA, because we don't allow access to the DNA data. No. Because we are a little bit afraid, right? So my question to all of you is also, reflecting upon this, don't we want to open this key? I mean, we have maybe 100 million data points of people around the world with respect to DNA. There's still a lot of data we don't know, and we didn't move from 20 years ago to where we are today. Almost not at all.
Well,
So-
I actually don't think it's because we do not open up for the data, because actually the case about the psoriasis patient, identical twins, it shows very much that a lot of diseases are multifactorial. There's actually very few diseases that are 100% genetic. So of course we can get led by, and the Danish, the Swedish study about the diabetes patients, I know that because I'm an endocrinologist, but that was actually led on by clinicians seeing a lot of patients and wondering why patients actually acted so differently on the medication. So they tried to stack them in different groups, and then they did the DNA testing and saw that they were actually different. And that's perhaps a better approach than in just doing the full body scan on the DNA, because it's actually the same. And we will get a lot of data, and we will do a lot of fishing, but will it make us any wiser if we not know what we're looking for? So that could be another perspective. I would like to hear something about inequality, because we in Denmark, we have a very noble purpose actually to diminish inequality in health. That means that every patient should has the possibilities to get the same amount of health and the same amount of treatment, and actually also benefit in the same amount. That means that we need to treat some patients more than others for them all to get the same out of the treatment. But I hear a monthly fee for using an app here. I could see a lot of patients that wouldn't allow themselves actually to pay that, or wouldn't prioritize not to pay that. I could see some concerns about do we lack a lot of patients that would actually benefit from an app like this. I could also see a society lacking dermatologists in this example, saying, okay, we just put it all on SkinVision or another company, lagging a few patients that actually should get a possibility to get treated. So I see a lot of possibilities actually to treat Denmark or patients in Denmark a long way from a doctor using technology. But I also see some kind of perspectives in actually raising inequality, depending on how well fit, rich you are to go into this type of technology. Have you given it some thoughts?
So we started the project also from the beginning on two platforms. So iOS iPhones, which are typically more expensive than Android phones, which also range, of course, in the price range, which is a quite a big effort, and again actually has slowed us down many times. But that is also to the aspect of equality a little bit, because we know that especially in certain parts of the world, people with lower incomes, they are typically on Android phones. So that's at least one effort we've undertaken to bring this technology out as broadly as possible. And you could always argue that people don't have even smartphones, but I think here we are also betting on the development, and even looking to developing countries within the African and sub-Saharan continent where they are kind of skipping our in-between step of the internet on desktop computers, going straight to smartphones and mobile internet coverage. But of course it's always an important discussion point, and we've also seen, I think, in England, NHS and Babylon Health, these aspects being discussed. Does it cater to the ones who pick up technology? What else can we do to, if we think about I don't know, my grandmother, could she actually use such an app and technology? And there's probably there's a trade-off of should this be a roadblock, or should we bring the technology to those where we can bring it to right now, and work together with the healthcare system? How do we take care of the rest?
So yeah, this is definitely one of the big things that we're working with, because we are a commercial company, and it is a paid product, and that's simple, because if we don't do this, then SkinVision will stop to exist, and we're not able to develop the application, the service, the dermatologists, to have them on board. So that's why we're trying to become a part of the health system where we are actually being reimbursed. And this is also because it's so different per country what happens. This really is the main goal that we have. We also are not expecting to be the complete, like taking over the role of a GP, of a dermatologist. But like we are just another way of getting there. Like we're trying to make this easier. But these are issues that we talk about on a daily basis, and I can talk about programs that we're working on where whenever you make a photo, someone else can make a photo for free, these type of things. We are working on those, but in the end, there will always be people paying for it and people that are not paying for it. But until we are completely reimbursed, this is an issue that we'll be facing.
I think it's just like the long waiting times for a dermatologist that is really the problem. So like maybe there should be more of them.
But that's just dermatology. It could also be psychiatry. It could be everything.
For sure. But there's like the waiting time and not being able to be treated by like a qualified doctor is a big problem.
I think maybe that an interesting aspect could be, I think what happened in Denmark was that all the personal access, and I think it was taxation or banking as a good example, a lot of old people also had to suddenly use computers and internet. And that's maybe there's a way in between where it's okay that those who are ready to adopt the technology get moved over, and that frees up maybe the time of the doctors to focus on those who are not ready to adapt the technology. But I think that's again this interplay between the regulation, the policy makers in the end, and to strike the right balance.
I have a quick question for you. So is there also a version of your app that is for use by doctors? So you could see that it was something like 60% for just a general practitioner to diagnose skin cancer. And you could improve that, right, by giving them the phone.
Yeah, no, this is also something. The thing is always that the only thing we don't have enough is enough resources to do everything we want to do. But we have also had a sort of an academy where we have these types of skin cancers lined up for doctors, and then they can go through it and train themselves, and we can tell them, are you actually as good as in recognizing skin cancer as you're saying that you are? So, or these are the types of skin cancer that you might need to practice on. So you have 100 cases and go through these. So we can use this data as well to help with these trainings. And maybe to also to continue on, like Stine, you said, like the big problem is the waiting time, and it triggered something with me. Is that the people that are using Skin Vision and that are paying for it are also helping the people that are not paying for it, because the moment you make a photo and we can tell you it's nothing to worry about, stay at home, do another check in 6 months or something, those are the people that are not going to the GPs, that are not going to the dermatologist, and they're freeing up the system, they're reducing the waiting time, also for the people that are not using one of these solutions.
Trying to go back to your zooming out, John, about all the data available. I'm curious about the comorbidities to psoriasis specifically, and it's a complex disease. You also alluded to it, Camilla. It's a complex disease, and imagine is a photo diary a very good Skin Vision, not a diagnosing tool, but an estimation tool, and then we have the DNA in a clinical trial setting. But how do we capture all the other data that is needed in order to adhere to a diagnosis, to adhere to a treatment? And that is one of our big issues, that we get a diagnosis, we get a treatment, but we don't really adhere to the treatment or follow the treatment for different reasons. Because we're in another place in our lives, we don't want to have methotrexate, we don't want to use that. I want to use biologics, or I want to use sun and salt water, and so on. So how do we capture, and that's really what you're asking, how are we capturing all of those data? So my question would be to Stine and Alex, where do you see you could enter all your other data that could be used in order for you to be able to control your disease or adhere to the treatment that has been lined out for you? I
actually see psoriasis more and more like coming to a AAA meeting, because it's like you're not, but because of the sense of that it's so many different aspects of how you live your life that actually interfere with your outbreaks, and it's very different from person to person. But But for instance, my dream scenario would be if I could go to Bispebjerg, I would not only see a dermatologist that would only either give me light treatment or some biological medicine or methotrexate or something like that. I would be able to see a doctor, I would be able to see a dietitian, I would be able to get my DNA test, I would be able to go with Adletogen that would maybe make a recommendation for me of how should I exercise, what other, like, should I do
psychologist,
psychologist or whatever, like especially like what would be good for me. And maybe I would choose 5 things that are my most important 5 things to take care of. And I think that's probably what I'm doing now. But if I could have it all in one combination, and then I think it would be learning for people to work together from different areas instead of have doctors standing on one side saying, what, this is a commercial company and what are we going to do? You know, it's a little bit like fear of each other doesn't really create anything growing or moving forward. So it's more of maybe working together from different perspectives. Yeah.
Absolutely. Maybe it came out wrong. So the commercial companies, they are the ones driving the technology. My point was really only that I think it's very important, and that would be my recommendation. I've said that to the Innovation Lab before. You need to think even more on co-creation.
Yeah.
So co-creation with the societies, so you have the doctors included. To me, it's not enough to have a couple of dermatologists, a couple of patients. You need to be on an organized level in order to get, for instance, with the Skin Vision and reimbursement. So you need to be even more focused, would be my recommendation, to co-creation on the technology, because then it will really benefit us as patients. What would be your take, Alex, on all the issues that goes into you being well treated for your psoriasis?
Well, I mean, I very largely agree with what Stine is saying. I also just think that, like, logistically, there's a huge problem in recording all the various habits, traits, thoughts, feelings, everything for every single person individually. And who's recording it also? I mean, that would also determine what gets written down and what doesn't. And I think it's a massive amount of work, and I'm glad I'm not the one that has to think of the solution for it.
Good. Maybe just close this one, Camilla, by saying you'll be very happy, and maybe you know that we have succeeded to get funds to start up a national center for autoimmune diseases with specifically focus on psoriasis, Crohn's diseases, and some arthritis diseases in Aarhus. And that will try to accommodate the need that you're verbalizing now, saying I'm not a patient going from one doctor from one specialist to another specialist. There's no psychologist, there are no dietitians. So here we're trying, in this national center at Aarhus, we're trying to really put the patient in the center of the treatment and have all of the specialties coming to you. It will start up for severe psoriasis, but that model will hopefully be implemented within the dermatological area in all parts of the country.
Would that be covered through the general healthcare system?
Yes.
Yes.
All right.
Oh yes. This is Aarhus University
What
Hospital.
about us poor people?
Excuse me?
I was just about to say, what about us poor students?
Yeah. No, don't worry about it.
Well,
That's
that-
part of the paradigm shift, I think, Camilla, that we're into right now.
Yeah,
the
and
holistic approach.
I will actually just make the comment that from a doctor's point of view, we're not we're not against this, not at all.
Yeah.
We have a focus on inequality, we have a focus on ethics and on data. And when you see a doctor, then you feel a little rough-headed on you. He's just representing a system that offers this amount of treatment.
Exactly.
And he's actually not in charge of doing any science on whether or not vitamin A, B, and C should do what, this and that. But he's in a system that says, this is what we do, and this is what we treat, and dietitian and everything else, that is not what we have the money for.
Yeah.
But he tends to be the ambassador of that system when he sits in front of you and feels just,
Yeah.
And doctors can be like that, also just from personality. But I think that the way forward is this a greater amount of public-private collaboration on testing a lot of things. New technologies, new ways of thinking, new ways of working together, actually to improve health for everyone. So yeah, we're just on that. Yeah.
A question about clinical trials, because I really thought that was interesting. So whom else is into this area of using DNA for clinical trials? I thought that was an interesting take. And again, from a patient perspective, we certainly want to move from one-fits-all kind of treatment to a more precise treatment. So could you elaborate a little more on that? I thought that was very interesting.
I actually think it's a really kind of untapped resource, and it's a wasted opportunity every time you run a trial and don't collect the DNA from those people. Because you're collecting all this other information, you're collecting the health information, you're monitoring blood markers and all of this stuff, and you're missing out on part of the picture if you're not collecting DNA data. So that was one of the reasons why in my project it should be very, very easy for anyone to run a clinical trial and just plug in this kind of DNA aspect to it and get the data, and it's standardized data using, you can compare it to all different trials, all different data sets, and it should just make this whole process very, very easy.
So is this ongoing at Leo Pharma? Is this something that you're actually developing new chemical entities in regards to using,
It's early days.
It's early days,
Yes.
yeah, okay.
So I would like to pause for a second and ask if there's one or two questions in the audience. There's one in the back. That was the first hand I saw.
I just want to ask, like, the scan that you're doing at Leo Pharma, is that a targeted scan, or is it a whole genome or exome scan?
Yeah.
It's an array chip from Illumina.
Okay, so it's a targeted.
That's not whole genome.
So what is it covering?
I mean,
900,000 bases.
Yeah, 750,000 plus 50,000 specially chosen by geneticists for medical diseases.
There's another question?
Yeah, I was interested about the harms part. I think you had touched a bit upon it with the random findings. But I read 3 really cool apps or interventions or whatever you would call them that you've shown here today, and with a lot of similarities, even though they are pointed at different parts of the patient journey. But they are interventions. They do intervene in people's lives, and they should maybe be considered like that. And I wonder, how do you include or look at or examine the possible harms with these interventions, the adverse effects that you do not anticipate, the patientification, you could maybe call it, the negative focus on health, and all these different things that we know other more traditional interventions, patient educations or screening tools can make. Are there focus on that research area there that can enlighten these areas as well?
Brief answer from.
Yeah, I think here it is about to work really closely together with the medical practitioners, setting up the right studies that cover not only the intended outcomes, but also psychology around patient satisfaction, quality of life, all these aspects together, and that's where we are actively looking for collaborations to carry out these studies.
I just want to add, I really think that there's a very big importance in remembering that whoever goes into any kind of treatment or clinical trial or whatever, they're really, really interested in trying to alleviate these symptoms, trying to get over this disease or whatever it is. And that can carry you a lot of the way through whatever hassle you have to go through, because you can carry the hope that maybe this will work, maybe this will make a difference. And that way, whatever seems like a big hassle or a huge ado about nothing may actually be worth it, because it gives you hope.
Okay, I'm sorry we have to stop here and pause, but you are more than welcome to approach afterwards. Time is up. Thank you so much, Lars, Camilla, Adrian. Thank you so much for traveling all the way from the Netherlands today. Alex, Stine, and Katie, thank you all